Hello, and welcome to BD's Virtual Customer Series, December 2020. All together now, driving patient-centered care through connectivity. Today's the first of a series of virtual customer series where we're looking at driving patient-centered care through connectivity. Our multiple sessions today, this is the third in the series, and again, welcome. We're bringing together industry experts, BD customer thought leaders, and BD clinical experts for learning and actionable insights. This is produced exclusively for BD customers of all disciplines and all levels of leadership. Today's program focus is on diversion, uncovering the unseen, revealing actionable approaches to diversion management. And please be looking forward to the next set of virtual customer series next February. In this session, what's working? Learn top diversion management techniques from industry innovators. Every healthcare facility, regardless of affiliation or size, must develop a diversion management strategy. The distinguished panel I'll introduce in just a moment brings together diverse perspectives from different organizational settings. These operational experts across the country will share their pearls of wisdom and insights of effective methods and technology to drive processes aligned with regulatory compliance and industry best practices. The panel will also address solution selection criteria, implementation, and their experiences. It is my pleasure to first introduce our moderator, Dr. Donia Dumitru as Senior Director of Medical Affairs, Enterprise Medication Management at BD, focusing on dispensing and analytical solutions. Prior to BD, Donia served in various healthcare operations, clinical informatics, and clinical practice and leadership roles. Just prior to her BD experience, was Director of Pharmacy at Memorial Hermann Healthcare Center in the Woodlands. Graduating from the University of Illinois in Chicago with her PharmD and also her MBA from Lake Forest Grad School. Joining on the panel, it's my pleasure to introduce first Dr. Caitlin Hipple, who is a manager of pharmacy clinical operations and the HSPAL Resident Program Assistant Director for the University of Virginia Health System in Charlottesville. Prior to her position at UVA, Caitlin was in residency at Allegheny General Hospital, and in addition to her PharmD from West Virginia University, she is a Master of Public Health from the University of Pittsburgh. Next is Dr. Alex Raymond, who oversees the Ochsner's Drug Diversion Prevention and Response Program. He's a graduate of the University of Mississippi School of Pharmacy and completed a health system pharmacy administration residency at Wake Forest Baptist Health in Winston-Salem, North Carolina, with a Master's of Pharmaceutical Science focusing in health system pharmacy administration from University of North Carolina at Chapel Hill. Next on the panel is Dr. Liz Wade. She serves as the Medication Safety Officer at Concord Hospital in Concord, New Hampshire. She previously served as the Medication Safety Officer for the Adult Med Surg at the Johns Hopkins Hospital in Baltimore. She earned her PharmD from the Northwestern University School of Pharmacy in Boston. She completed a pharmacy residency back in 2009 and a medication safety specialty residency in 2010 at the Johns Hopkins Hospital. And our final panelist today is Dr. Steve Webster. Steve is the Chief Diversion Officer and Associate Director of Pharmacy, Drug Diversion Detection and Prevention at the University of Rochester Medical Center in Rochester, New York. Steve received his PharmD at the State University of New York at Buffalo and his Master's in Medical Management from the University of Rochester. Thank you, panel, for joining us today. We're looking forward to your participation. Donia, thank you.
Thank you, Perry. It's a pleasure to be with you today and to host this distinguished panel that we have today. Now, before we dive into our discussion, I did want to let the audience know that in full disclosure, this program is being sponsored by our company, BD. Now, before we dive into a number of questions related to lessons learned and experiences that our panelists have prepared for today to share with us, we first want to set the stage for those responses by providing two pieces of background information about the organizations each of them work for. So they're going to cover two pieces of information for you. The first is they will give us an overview of their healthcare organization. And then the second part will dive into describing their organization's diversion management structure. And with that, I'm going to turn it over to Liz from Concord to start us off.
Thank you, Doina. So Concord Hospital is located in New Hampshire, and so that's one of those little states in the Northeast there. And we serve over 50,000 people in the region. It's comprised of an acute care facility that's 295 beds, as well as 27 different locations for primary care and specialty practices. Concord Hospital is, as far as being located in New Hampshire, we certainly have our experience with the opioid epidemic. And so our Narcotic Security Task Force was established in 2012. It is multidisciplinary for the enterprise, and I oversee that task force. This reports to our senior management team, which is on the Quality Management Oversight Committee. And you can see we have a number of various subcommittees and work groups that don't all meet consistently, but have over the years met to accomplish different tasks as part of our program. And I will hand it off to the next panelist to do their introduction.
Alex, would you describe Ochsner's approach for us?
Hey, thank you for that. So Ochsner Health System is located in Louisiana and covers parts of Mississippi as well. It's 11 hospitals owned and managed by Ochsner proper, with 19 affiliated hospitals, and we see over 800,000 patients a year. Going more specifically into our drug diversion management program, we've recently we've been monitoring drug diversion for years at Ochsner Health as individual sites. Last year, we made the plunge into setting up a corporate compliance division to oversee drug diversion prevention and response. That's where I fit in, under a team with 2 nursing auditors, myself as a pharmacist, and 2 pharmacy technicians. We actually report up to compliance and privacy. From there, my team leads drug diversion response teams at all of our owned and affiliated hospitals. Right now, we're at 14 sites. And then all those information is compiled and sent through our System Drug Diversion Oversight Committee, which has C-suite representation. That information is then dispersed through System P&T and opioid stewardship, and the information, funnels down back to our team of what we should work on. Definitely a unique process from what I've worked in the past, and we continue to grow.
Thank you for that, Steve. Yeah.
So the University of Rochester Medical Center is located in upstate New York. It is the largest healthcare system in upstate New York, with our main flagship hospital where my team works out of, Strong Memorial, with just under 900 beds, multiple regional hospitals, and multiple care sites. Within our large hospital, we do a pediatric hospital, trauma center. In regards to our diversion, how we manage controlled substance handling and diversion, we have myself as the Associate Director of Diversion Detection Prevention, also serves as the Chief Diversion Officer. I also lead the Controlled Substance Steering Committee, which consists of basically the C-suite, chief operating officers, leaders from all departments of the hospital. And that team really guides what our operational diversion prevention team does in regards to projects. Our operational team consists of 3 analyst FTEs, one that focuses primarily on inpatient nursing and pharmacy, one that focuses primarily on what's going on in the OR with anesthesia, and then one that's for our ambulatory procedural areas. And then finally, we have a 1/4 FTE nurse liaison on our team, which has been a big resource for us in regards to education and just understanding nursing workflows. And our entire team falls under our chief pharmacy officer.
Thank you, Steve, for that. I'm going to ask Caitlin, would you wrap us up with your experience at UVA?
Absolutely. Thank you so much. And I'm really excited to be sharing the University of Virginia's experience with everyone else here on the panel as well. It's been really great getting to know all of their experiences and their journeys. And ours started right when I kind of got here around 2016, and we are growing. The University of Virginia actually just went through quite an expansion, even though COVID hit us. And so we are now at 631 licensed beds, and we're still continuing to grow our operating rooms and procedural areas into this next year. We just expanded our emergency department. So the year 2021 is looking like more expansion, which means more need for controlled substance diversion proactiveness for us. And so absolutely looking at all of our stats there and our demographics, just to give you a feel for the University of Virginia and what we have going on. Our tactics really focus on the main medical center, and this doesn't preclude anything, though, that we also oversee. The diversion tool that we use focuses mainly on the inpatient setting. However, we still have to use a lot of manual approaches to medication inventory systems and controlled substance monitoring beyond the main medical center, which includes our cancer center, our children's hospital, our transitional care hospital, outpatient clinics, and retail pharmacies. But what we focus on at the main medical center that does also hit these areas is our Pharmacy and Therapeutics Committee. So we use a very structured approach to our Controlled Substance Oversight Committee, which is a couple committees down into a subcommittee from our P&T structure. But that really gives us the leverage that we need to make really big decisions and to get that buy-in and not make it so transactional at our organization. You'll see lots of different varieties of individuals included on these committees, and this structure gets reviewed annually, and we update that membership on that annual basis. And so this way we have that actual variety that we're looking for in those committee members, and we get new and fresh perspective. We have one controlled substance oversight diversion committee, and then a second one that is devoted to the perioperative area, because we have understood and realized that is need for extra focus. And then we also have a pretty aggressive focus on when there is suspected diversion, whether that be behavioral or from our surveillance initiatives that we have going on, especially with the BD tool that we're using. So this just kind of does a broad overview of our process and what we've done at the University of Virginia these past 4 years.
Fantastic. Thank you so much, panelists, for giving us an overview of your organizations, but also very importantly, how you have currently structured your diversion management programs. An excellent overview and perfect stage setting for diving into our discussion now. And we've got a series of questions that we're going to be using to talk about this critical and important subject. And first, what I'd like to do is start with some questions around the process that you used in making the decision to augment your programs with a tool, specifically the BD solution. And this is actually one question. I've divided it into two, but I'm going to ask Steve and Liz to help us with answers to this series of questions. So first, what was your diversion management process before BD's solution was chosen? And then why did your organization embark on implementing a new diversion tool. Steve, I'm going to ask you to start us off.
Okay, so on a daily basis, our drug diversion detection prevention team is going through EMAR data as well as our Pyxis data and making those reconciliations. When we start looking at trending, we're using things like, we've gone away from using basic standard deviation reports and using more of a data aggregation software. Unfortunately, as many people know, that process leads to a lot of data, and within that data is a lot of noise, and it becomes a very inefficient and manual process in regards to trying to find true diversion cases. So that sort of led us down the pathway of trying to find an advanced analytics solution that would allow us to be more efficient in the way we both routinely monitor for controlled substance diversion, and then when we actually have cases pulling the data. And so looking for that solution would then allow us to expand from currently where we just have, where we just oversee one of the hospitals to be able to oversee the entire IDN as a team.
Excellent. Thank you for sharing that, Steve. Liz, what about your experience at Concord? We're going to go to Liz. Thank you.
Hi. Yeah, so our audit program, just to give you a little bit of background, is a decentralized program. So we run our controlled substance audit program centrally through the pharmacy and through med safety. But all of our auditing is actually done by nursing leadership for their area. And so our audit program's been in place for about 7 years, and over that time, we've probably undergone 4 or 5 different renditions of how we do the audit, because each time we have a diversion case, we like to, update our auditing, or if we hear about cases externally, we like to update our audit program to make sure we capture all of those data elements. So what that has ended up with is we now have at least 5 different reports that we reference on a monthly basis. And I'll be honest, I dread the first of the month. Like yesterday was December 1st, and I probably spent like 3 hours pulling reports for all the things that we monitor. And one of them is a homegrown report that we built that actually reconciles all Pyxis transactions against documentation in the EMR. So it actually pulls all those and does an automatic reconciliation, and we have that generate on a daily basis. And so that goes to our nursing leadership, and they are completely inundated with the amount of reconciliations. Our initial thought was, anytime there's a discrepancy in documentation, we should be following up on that and correcting that documentation or investigating it. And it has become so overwhelming that areas from especially critical care and the peri-op setting have just cried uncle and just said, we can't keep up with the volume of reconciliation issues that we have. So between that and probably running 5 different other reports, canceled transactions, standard deviations, we still have not actually uncovered a diversion from that audit program. All of our diversion cases until this point have been based on other tips and other reports and reports from other employees. So I think we're really looking at what the future holds for auditing. Can we be more efficient and use our resources more wisely, as well as actually develop a solution with some artificial intelligence that can actually detect diversion amongst many factors that we're beyond human capability able to do manually.
Thank you, Steve and Liz. Both of you describe honestly, a very clear mental picture of what base state, if you will, looks like. Lots of similar themes there. Report running, lots of manual reviews of reports. Liz, you said it well, dreading certain times of the month. I think all of that description leads to a very natural next question, which I'm actually going to pose next to first Caitlin and then Alex. And if the two of you could talk to us about which multidisciplinary groups were involved in your decision-making process in terms of finding a new solution, a different way of attacking this challenge? What were the key requirements that you were looking for in a new tool? And then if you could also touch on which discipline led this effort in this project on this journey. Caitlin.
Absolutely. So as I mentioned before, we have a very strong, large multidisciplinary committee in our music structure. So this went to our Controlled Substance Oversight Committee. And the key players here were, of course, nursing. We have anesthesia colleagues on both the perioperative committee, but also our other just Controlled Substance Oversight Committee. So they were really key into this as well. Quality, we have a quality coach that is on this committee helping coach us through a lean process assessment. So we are definitely a lean hospital, and we definitely want to assess and work through problems and try to get to the root cause. So that was part of our assessment in this group. Informatics is really strong, so data was big. And part of that was the pharmacy and nursing dynamic that Liz actually explained previously, where you're dreading that reconciliation of data from Epic and Pyxis for us and how we looked at those reports. So that was reported up and provided to our P&T committee to help leverage that approval process to go forward and look for opportunities to partner with someone to be more advanced in what actionable items that were out there and tools that we could utilize, because some of the tools that we were exploring were not working for us. They were really lackluster, and we were looking for something more advanced, and knowing that some AI and machine learning options were becoming available, that's really what drove us there. And having a director of nursing governance was really crucial for us as well.
Alex, what about Ochsner's experience with this?
We started this journey about 2 years ago, looking at advanced analytic platforms and really diving into them. We brought in 3 vendors to present to our primary drug diversion response team at our flagship hospital. And from there, the ball was put in pharmacy's court, where I previously sat before moving over to compliance, that pharmacy would make the decision. BD's time-tested reputation with other products and proven track record kind of made it a no-brainer to go down the health site analytics route. From there, our local drug diversion team at our flagship hospital gave the approval, and then the decision was to expand it across the system. The implementation process was actually led by myself sitting in compliance. So this really gave us a unique perspective coming from a different department, not pharmacy, not nursing, not anesthesia, to really promote the product and help implement it, and really promote the product in the front line as well.
Thank you both so much for that. That was an excellent overview of that critical decision-making process for your 2 organizations. So we're going to actually switch gears a little bit, and we're going to move toward another important topic, and that is it's obviously very important to make a decision on which way you're going to go, but once you've made that decision on a new solution or a new tool, if adoption isn't there, the journey won't succeed. And so I'm going to actually ask each of our panelists to answer this question. Each of you has a very different, similar but different journey. And what we're going to touch on here is, I'd like to hear from each of you on where are you in that adoption journey of the solution. Talk to us a bit about your system rollout and how you're doing that. And then, always very important, what lessons did you learn so far? Caitlin, would you start us off on this one?
No problem. So we are 1.5 years exactly into implementation optimization now with the BD Diversion Analytics tool. We went live in May 2019. That was precedented by 2 years of hard work to get us to a point of implementation optimization. So I think if you are implementing something like we are, we're still going to call it like optimization phases, because you should be doing that constant process improvement evaluation cycle. And I think the biggest lesson learned was finding a champion not in pharmacy for us. It was critical to driving the adoption and how mass marketing and engagement went for using the tool. It really was the strongest piece for us, and especially with our nursing colleagues. Figuring out how to build that strong partnership with those key stakeholders is really essential, and having that right fit of that champion. So you really don't want to just willy-nilly pick somebody. You want to make sure that it's going to be the right fit that will drive that message and help the development and implementation process.
Excellent points. Alex, what about Ochsner?
So Ochsner is fully implemented with the tool at 14 different sites. And while the tool is implemented, optimization is continuing, as Caitlin said. It really is never going to stop. Some of the largest lessons learned that we took away is really adoption at each of our sites occurred in different phases. A couple of the sites are on the tool on almost a daily basis, while my team is doing proactive monitoring. They're running reports. They're really getting the most of the tool, and they're providing us with a lot of feedback to give to BD of how we can continuously improve the tool. Others who might be on the tools for the past 4 months might have logged on it once. So really, noting that the adoption varies from site to site. You're going to have some that are really eager for the change, and others who know it's there and just kind of trust it when they want to trust it. But really, having that champion, whether from pharmacy, compliance, or nursing, to drum up support for the use of the system is key too.
Yeah, thank you, Alex. Liz.
Hi, so we actually just implemented the software in July and went live then. And, July wasn't exactly, the best timeline around COVID to roll out a brand new health system wide audit program. So we opted not to go live with active use of the software. Instead, what we've decided is to continue to monitor it and actually work with our nursing leadership to look at the software together and then discuss what our audit program will look like. So I actually just went to our nursing leadership council, last month, and all I had to do was say, no more manual audit. And everyone started cheering. I was very excited. And so we got to look at the software together, and they're very excited about the tool. There's a couple things that I think stood out to them, primarily, first and foremost, compared to the reports that we run now that are very kind of Excel based. This is a very user-friendly interface, so our nursing leaders really like that. They felt like it was really neat to see their staff members specifically for their areas kind of on a dashboard and look at compliance figures and be able to really assess practice on a more general basis for their area. A couple items of feedback that they have given, because our process is decentralized and is led, the nursing leaders are much more hands-on on the data. So they really want to be able to log in and look at what the practice is for their area. So they've actually requested if they could filter the the front page, the queue with the risk analytics scoring for their area, so that they're not just viewing for the whole house, they're viewing the risk score for their staff only. And I thought that was a brilliant idea. So I've shared that with the BD team. An enhancement request is in place. And there's definitely some other things that, like standard deviation, they'd love for that to be included on the compliance report that currently is not, that lists all the staff members and their different statistics. So I think we're getting some really great feedback from them. I think including them as part of the process to discuss what our new program will look like and having them design it is going to help facilitate the adoption, because they're going to be the champions and they're going to be the ones using it every day.
Some excellent points there. And maybe what could be a new slogan, no more manual audits.
Okay.
Steve, your experience at URMC.
So we were scheduled to roll out, to go live in March of this year, 2020. But unfortunately, COVID derailed us, along with a lot of other things. It shifted our priorities, particularly on our IT side, away from projects, unfortunately important projects like this, to surge planning, and then eventually to financial recovery projects. So we have been delayed to looking at the early part of 2021 to roll out. We actually have learned quite a few lessons so far, and actually my colleagues on my fellow panelists here have definitely helped me out. We'll definitely utilize our nurse liaison to get buy-in from our nurse managers. Our nurse liaison on our team is actually a former nurse manager and is a very well-respected member of the nursing community. So I know we'll have success getting buy-in there. And then the other part is making sure our IT team is aware of the project early on. Was something that we learned a little bit the hard way. So.
Excellent. Thank you to all four of you for sharing some excellent feedback and observations of your journeys so far, specifically focused on the adoption of the solution. I'd like to continue that theme, though, with another question. Very passionate about this topic myself. If your team doesn't know how to use it, again, it's not going to get very far. Adoption won't go as you had planned. And I'm actually going to ask Alex and Caitlin to take this question. And if each of you could go into describing what your staff training process was for the solution as you deployed it. And then also, curiously, did you uncover any practice or perhaps solution or system opportunities throughout that training effort? Alex.
So first and foremost, my team, 2 nurses and 2 pharmacy techs, they were trained first on the insides and outsides of the program, considering that they are going to be the primary users of the system for it. We did roll it out to our directors of pharmacy and CNOs trains. We actually used BD's virtual classes just to review the basics and understand this is what the dashboard looks like. This is how you click in the program. After they reviewed the basics on their own time, BD assisted with training, and we actually had 4 go lives and staggered across the system. Each go live, we went live with about 3 to 4 sites and offered 2 in-person training sessions in our live environment for one of the sites that was going live. After the official go live week, my team then rounded with the DOPs and the CNOs to see how they use the system and their understanding of how it works. By the end of it, I feel like most of them were pretty competent on the basics. So I felt pretty confident with how it went. Some of the biggest successes so far, we're no longer bean counters in the pharmacy or compliance department where we're looking at standard deviation reports and saying, maybe this person has a problem. BD lets us dig into using the compliance report on where are delayed waste occurring, where are excessive PRN administrations occurring. Using those compliance reports and really honing in on, where delayed waste, delayed administrations, missing administrations are occurring from one centralized system was really the biggest win. And actually going to our local drug diversion meetings across the system and showing them that data of comparatively on a unit, why is this person delaying all their admins? They might have 8 in a month where their peers might have 1 or 2. So it's a lot more meaningful and actionable data instead of your typical discrepancy and standard deviation monitoring.
Excellent review there. Caitlin, what about UVA?
We did a large amount of in-person training. It started with BD having a lot of sessions with myself and one of our other managers, who is the manager of our informatics, and then identifying 2 nursing partners who were our nurse managers, who they came on and did a lot of intensive training, did a lot of development and early vetting of the tool as well. So they really intimately knew all of the process. We then had and held, between the 4 of us, live sessions, and we would make them a variety of times. They were hour long, and they wouldn't normally maybe last the entire hour if we didn't have as many people there. We would max out to about 8 people per session, and we held them different times all day throughout the week. And this went on for about a month and a half of in-person sessions, and they could sign up, and we were keeping track of who signed up, and then we would send out reminders if some nurse managers or assistant nurse managers weren't signing up, so that way we could identify and even go in person to them if they needed to, and actually get them, the frontline nurse managers, engaged, and a chance to see the tool firsthand, because I really think that it's such a really great opportunity. And I think once you see it and get to play with it and get to know what's available in there, it just really ignites them to want to walk through a case. And so we then would pick out someone and walk through a case with them and started seeing trends. And that's where we actually received a lot of feedback when we were funneled that back to BD for enhancements. One of those was just the active learning about fentanyl and how the data stream between Epic and Pyxis was causing everything to be unreconciled or look like problems for every single person with fentanyl. So that was a great thing that was identified and fixed because of the tool and found. So that was amazing. So a lot of things just coming up in terms of how they could use it daily. Like Liz's nurses, they got really excited and want to be in there every single day. They want to be in that reconciliation tab and looking proactively to see if they can resolve issues and problems, and really just having that opportunity to address it with them. So it really got them fired up and excited. And you saw a lot of strong engagement in like when they actually go in and use the tool. And so there was really good adoption of the tool. And then we've had to do refresher sessions because there's been updates, and definitely have received feedback. And so some of their feedback has gone into enhancements and updates. So they really loved to see that and like to actually get to the opportunity to experience those new updates. One of the other things that came about this was the whole dose waste. I think that was something that was really eye-opening to see too. So if there is whole dose wasting, that's pops to the top, and you can see it's easier in the tool, and it's a one-stop like spot to evaluate without switching back and forth between multiple platforms, and just really has an easy use for the nurse managers and us.
That's incredible. Caitlin, I don't think if you'd asked me early on in my career, if I'd ever hear in my lifetime that nurses, especially nursing leaders, would be excited about a diversion investigation, I would never have believed you. Some incredible experiences, early experiences that you all have had, even just through your training process. Incredible story. So, Caitlin and Alex, I'm actually going to stay with you both as we move to another question related to the adoption of the solution. And I think you've each touched a bit on this, but anything else to add on any other reactions or feedback that you've gotten from your teams involved with this process?
A big sigh of relief. I think that was the biggest overwhelming response when this actually went live, and we were able to start doing a lot of our documentation and investigation through the tool. It simplified a lot of our workflows. It replaced a lot of time nurses spent on investigations, which is really a big pressure release for them. And it also saved us a lot of email space because we were doing a lot of manual process communication, Excel document sending back and forth, which really clogs up your email capacity. So I think that was just a big relief to not come in almost every week, for me every day, locking my inbox up from all of that communication. And I think it really just helps standardize their daily workflow. They look at this every single day. They want to look at every single day, and it just is making these really complex investigations simpler for them, and just creating that different culture.
Excellent. And Alex?
Relief. I believe, has been said multiple times. Our compliance team was relieved. They're no longer the bean counters that match transactions. They're actually using their clinical skills to dig in deeper, and if something is going on, they're able to kind of snuff it out. Our proactive monitoring reviews from last year, running the data this week, we're up about 400% on individuals we have proactively monitored, thanks to having this tool for only about 6 months implemented at Ochsner Health. Our frontline nursing leaders, they're thankful for it because they get, real-time actionable data that they can kind of target their education and their coaching on the floor, whether it's regarding, canceled transactions or delayed waste. I feel like there's a sense of relief from our directors of pharmacy across the system, knowing that this program exists and there's a team dedicated to using it and managing it, keeping their patients safe and their drug supply intact. All around positive feedback.
That's good to hear. Another word that absolutely resonates, relief. You're right. We have heard that many, many times already, just in this short time together. So I think each of the experiences, panelists, that you shared and the lessons you've described, very insightful and honestly very practical. I know that each of your stories will resonate and does resonate with our audience. But your journey isn't over. And I know that each of you have thoughts on future opportunities as we partner together on this journey. And I'd like each of the panelists to share what is most important as we look toward the next phases of developing the BD solution. Steve, would you start us off?
Yeah, so I think obviously for us, one of the areas that's a big unknown often is what's going on in the OR. And about a quarter of our controlled substance use happens in the OR space or procedural areas. So being able to get a better picture of what's going on with in the OR with our anesthesiology providers, being able to get that data to anesthesia leadership, being able to look at things and compare different providers across medications that they use and compare that with their case types and their case times, I think would be very important. I think another area more in the inpatient realm would be continuous infusions. So there's a lot of, again, unknowns that happen around controlled substance infusions when they're switched out. We're lucky enough to have Alaris interop at University of Rochester Medical Center, but we haven't yet leveraged that data, the infusion data, with controlled substance data to be able to really marry it and see if we can identify trends there.
Excellent, thank you. And Liz, what about you?
Yeah, I have to echo Steve there. All of our diversion cases, I can say, have either happened in our emergency department, our critical care areas, or our perioperative areas. And I think those are right now, opportunities for growth with our diversion software. As Caitlin alluded to, we have a lot of noise right now in the software, and that's part of my hesitancy against kind of rolling it out early on right away to all of our nursing leaders is because of all the noise from the continuous infusions. So, our nurses are documenting our continuous infusions in the EMR, but that doesn't seem to be communicating with the BD software. And the other thing that's providing noise right now are also any non-medication items that are in the Pyxis, like keys and whatnot, also seem to be providing a lot of noise. So I think we're still working on fine-tuning some of those things, but I think as we, as we move forward, the continuous infusions, peri-op, emergency department will be our areas of focus.
Very important areas indeed. Caitlin.
I echo everything that Steve and Liz have said, but I think in addition, there's also opportunity. I think pharmacy gets looked at, or it's at least called to the mat to kind of look at our supply chain accountability. And I think that would be something that we can adapt maybe more into a tool like this to have it integrated and all in one place. Be able to track our full chain of custody within pharmacy. Currently, nurses want to know more about how we track our own pharmacists and technicians, because since we track them and our providers so well, they want to really know what's going on, where the drugs are being handled by the pharmacy department. We do a lot of compounding, so a lot of the controlled substance compounds, it would be really nice to have that in one location. It covers some of the gaps from our C2 Safe and our EPIC documentation with compounding or packaging. I think there's a lot of progress being made there with a lot of just integrated technology. We use EPIC Rover, and it captures a lot of tech timing, and it could be integrated probably with our BD tool and showcase some more things that I think would be applicable maybe to the pharmacy transactions and supply chain accountability that we might be looking for.
Excellent points. And Alex, any final thoughts on future opportunities?
Yeah, I'll echo what Caitlin said regarding the pharmacy monitoring. As she said, we're always looking at nursing and pointing them out, why are they delaying waste? But if we could really show, our full chain of custody of where we're receiving our medications, how long do they take to get implemented in the C2 Safe, how long do our deliveries last, having that transparent process on this system would, I feel like, make everyone sleep a little easier at night, knowing that we're not just targeting one profession compared to another. I also think it would be interesting seeing your local institution's pain management policies and or DRGs within the system. Knowing are our providers working within the parameters of the orders? Are the administrations consistent with the diagnosis that the patient has in the hospital? Explaining 2 milligrams of hydromorphone every 4 hours for a sickle cell patient, that makes sense, but really, does this pneumonia patient need that amount of morphine? So looking at that information all in one system would definitely, be beneficial for us.
Thank you. Thank you so much, panelists, for taking that question. I think your answers highlight something for me that I think maybe we could even call it a universal truism, but I think the more data we have, the better tools we have, and the deeper you dig into this data and trends emerge, the more questions we have, the more things we want to look at. And I think each of you summarized many future opportunities, and that truly, I think, speaks to how complex and how honestly challenging this problem in healthcare is. We have a lot of work to do to solve this issue for our profession and for our colleagues. And thank you for partnering with us on this journey, panelists. And with that, distinguished panelists, thank you so much for your time today and the very valuable and practical insights and lessons learned that you shared with us. We've said over and over, this is a complex organizational process. It's a complex issue, but the pearls that you shared, your learnings, have given us a very diverse view of how each of you has addressed this challenge and what you're continuing to do to solve this problem. On behalf of our BD team and on behalf of our panelists, thank you for attending this session, and we look forward to the next session. Perry, I'm going to turn it back over to you.
So let me just offer my thanks to the panel and also you for moderating. I think of the pearls that all of the attendees today would gather. Certainly motivation for those that are forming their own diversion management teams. You saw examples of the constituents that our panelists added to their individual groups, but you also saw the adoption rates. You also saw their other pearls of wisdom. So again, thank you, panel. Thank all of those that are attending. This concludes this third segment of today's virtual customer series. And we'll ask that you close your browser, and we'll start the new series at the final segment at the top of the hour. And again, on behalf of BD, thank you for joining.